Did you know babies have mental health? Yeah, they do. Learn about what affects infants and toddlers' mental health and about the impact postpartum depression has, not just on the mother, but on her baby and the rest of the family. Next on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. And tonight we're taking your questions on infant and toddler mental health because really we need to know more about this topic, especially since when we know better, we have the opportunity to do better. So call the numbers on your screen right now. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. And you can also text us your questions or email them using the number or address listed at the bottom of your screen. We're going to start by introducing our guests. Casey Ladd is the Director of Child and Family Services at the Human Development Center, where she developed the Early Childhood Mental Health Team. She also provides training and consultation across the state to assist in addressing the mental health needs of infants, toddlers, and their families. And Dr. Marianne Marshall is an Associate Professor of Education here at the University of Minnesota, Duluth. She has 30 years' experience working in the field of early childhood education and development, and for the past 15 years has been engaged in research and training in the area of infant and early childhood mental health. Thanks to both of you for coming out tonight on, I think this might be the coldest of the winter evenings that we've had so far. And we need to start, and I think, Casey, I'm going to start with you, by even defining what infant mental health is, because I got to tell you, this afternoon, I was over at the courthouse talking with a colleague who asked me, well, what are you doing on the show tonight? I said, I'm doing infant mental health, and she gave me this look and said, I know, you didn't even know that they had mental health. She's watching with her grandbaby right now.
Good. I hope that she's enjoying these sweet smiles that the baby is hopefully giving. The definition of that Marianne and I both were trained in understanding infant mental health comes from an organization that's the diagnostic classification of 0 to 3-year-olds. And when we look at how do we assess the mental health of an infant or toddler, there are 4 components that we look at, Carolyn. The first is, what's the baby's capacity to express and regulate their emotions? What's their ability to form and maintain a relationship with an available caregiver? And what's the baby's capacity to explore their environment? Because if babies can't explore it, they can't learn. And the fourth is that we're looking at and assessing this all in the context of the family systems that the babies are born in.
And so tell us a little bit just about even why this is such an important topic, Marianne.
Well, the current research, actually research from the past 15 years or more, suggests that we miss opportunities if we don't encourage infant mental health, as Casey has so eloquently described, meaning the context of the relationship that happens. If we don't figure out ways to support and embrace our work with families early on, we're missing those very foundational experiences that set the template and the working model for how children will negotiate and embrace experiences across their lives.
And when I was doing some reading to prepare for the show, I read this statement where it said the 2 most important things for the infant's developing brain, one is food. I think most of us could guess that one. I thought, well, okay, that's a no-brainer. And the other was just their contact, their human relationships that they have.
Yes.
Which is amazing when I think about that is what the brain needs.
That's what the brain needs
to develop. So tell us talk a little bit about attachment and bonding, because I know they're not exactly the same.
They're not exactly the same. And so you're absolutely correct. When we look at infant brain development, that the baby needs to have that social interaction with caregivers. And babies don't attach to us until, this was shocking to me, I had to reread this. The babies aren't attaching to us until about, between 6 and 7 months. They're practicing attachment behaviors all the way through. We bond with the baby, and ideally the baby has not one or two, but a community of caregivers who are really attuned to what the baby needs, because the baby is signaling up from the moment of birth, and that what the baby needs is somebody that's really tuned in to accurately reading what the baby's signaling. And as that I think of it as that delicate kind of dance begins over this time, about 6, 7 months, the baby kind of becomes very preferential in who am I going to attach to. And this happens at a time when they're starting to be a little more mobile, and but they can also, their brains have developed enough that they can begin to remember, I like the way you hold me a little bit better than I like the way you hold me. And so they'll make that kind of preferential choice at that age.
And you're not saying that the relationship doesn't matter before 6 months.
No, no, not at all.
You're saying that the baby doesn't have those preferences and that attachment to a caregiver or to caregivers until that 6 to 7 month period.
One of my questions, Carolyn, was, and I recently had to do a research paper on, why do babies have the stranger anxiety around 7 months old? It's kind of like, well, why don't they have it earlier or later than that? And because it's at that time that they're beginning to remember and realize that I really do prefer this caregiver. And, in our culture we tend to think of that as the mother, but that's not necessarily the case. It's, for the baby, it's who's the person that I can count on the most, who understands me the most, who's the most reliable to meet my needs. And and so we would say that all of those relationships are very important. And the more people there are available to love that baby, the better for the baby.
And I was just going to ask about that in this culture we always think mother-baby, but it could be father-baby,
Sure could.
or it could be 4 different people. Can you talk a little bit is there a preference?
I think the preference is predictability and unconditional access. And when I say availability and accessibility, I mean emotional availability. So who is the infant able to connect with in a consistent way, time and time again? There's some research that suggests, there's a gentleman by the name of Ed Tronick who does work with the still face experiment, in which he has moms and babies engaging with each other. So they're doing this incredible, the way they maybe they're playing.
Even 3 months old.
At 3 months old. And they might be doing something with this little piggy went to market, or some sort of finger play, or playing with their toes, something that's their way of communicating and engaging in a joyful way with one another. So he has moms and babies engage in this way. Then he says to the moms, okay, now I want you to turn away and have a still face when you look at the baby. And then he proceeds to look at what happens with the baby. And it's quite striking to see what happens. The baby, initially starts to really recruit and signal, come on, I'm here, play with me. And I can tell, or you can't really tell, but I'm sure for that mom who's having this still face, it's like, oh my God. But eventually the baby kind of falls apart. And so babies are pretty competent early on at 3 months at really trying to figure out how to engage and signal partners in communicating and a relationship. And I think, that idea of practicing attachment, we see that. We see that really early on.
And so this, I think, is what a wonderful segue you have just led us right into, Marianne, because the story about the still face, where the baby falls apart when the caregiver is not responding. Let's talk about number one, first of all, maybe what are some barriers to bonding for a mother that create barriers in attachment?
Well, we
or
would
caretaker, maybe not just mother.
Sure. So we would see there are a couple areas that I know Marianne and I are currently working on in our community, and one are like families that are living in very, very elevated stress situations, where it might be a situation of family violence, of a mother who in a family where the stress levels are very high. The other is that we're very concerned about are those situations where mothers are depressed, and that we're actually in conversation with some OBGYN clinics in town to begin having them do early identification about women who are depressed in the latter part of their pregnancies, because it's not necessarily that they're going to have a severe postpartum depression following the birth, but for us to just be able to be aware, to be accessible, because when the baby is born to a mom who's depressed, who might actually have that kind of still-face situation.
Which I was just going to say, you know, that in fact, when I was in graduate school, what I was told by a professor is you'll recognize the depressed person in your waiting room because they look sad, and that is that still face,
Yes.
right? That is that no emotion showing on the face.
Available.
Right.
Yeah.
And so what we want to do in those situations, and as we've had families referred to us, it's to not just treat the mother in her depression. We have many, many skilled folks in our community who do that. But it's also to pay attention to what's happening to the baby who is with that mom, and we want to build and bring in ideal resources, you know, grandparents, aunts, uncles, siblings, who can be engaging the baby as the mom's depression is being treated. Mm-hmm. And I know that Marianne, we have a road trip that's going to be planned to Madison to meet.
Well, yeah, any excuse to go to Madison, right?
Because a woman who's piloting some really innovative research with moms with maternal depression.
Yeah.
And I know when I worked in a hospital setting in the early 80s, they were just beginning to do have this ability that if a mother was hospitalized with postpartum depression, that they actually gave her a room and brought the baby in too, so that they could maintain contact. And years before that, there was this physical separation, not just emotional separation, but physical separation. And it doesn't necessarily even have to be maybe a mother with postpartum depression. A child born with significant medical illnesses can complicate attachment and bonding as well, I would imagine.
Mm-hmm. Mm-hmm. Which is, I think, too, thanks to the work of people like Brazelton and Heidelise Alls, who have really looked at the very population you're talking about, babies who are born either too early or low birth weight and have some significant medical complications. And how do we acknowledge the fact that those babies, just like all babies, they're wired to connect, and they're wired to connect with this person who they shared a body with, or someone else who they know, you know, by being around them even in the prenatal period. So that idea of kangaroo care is something that's practiced in a lot of neonatal intensive care units, where parents will be allowed into the NICU as early as possible, barring any, you know, medical complications that would jeopardize the health of the baby, to engage in skin-to-skin care, so that the baby has access to the mom's or the dad's smells, their skin, and that then begins that very important bonding and attachment relationship.
And the brain development.
And the brain development.
That is, you know, is so incredibly critical, that without that social contact, we know that infant, toddler brains do not develop, that the synaptic connections that need to be made aren't happening.
And I think that was what was fascinating for me in my reading too, was just seeing that it wasn't just that it affected the emotional life of the child, but we're talking both structure and function of the brain. And in that first 18 months is where we're seeing this huge proliferation of both structure and function in the brain. The right side of the brain grows most at first, and that's the emotional, connecting, creative side of the brain. But we're actually talking here about this has impact and implications not just for your ability to connect with another human being, but your overall ability to adapt and function in the world. Let's talk a little bit, Casey, about what an infant's reaction might be to a world that doesn't have that kind of human connection.
Well, what we'll see is that, that the baby will oftentimes, they have many different strategies about that they can try to engage initially with smiling, with some crying, with some whining, with some screeching, so that they'll get more distressed, because babies, they need us to help them learn how to regulate. They need us to help them learn how to go to sleep. They need us to learn how to comfort them when they're scared. Their brains don't have that ability. That develops in that first year. As we say, that one of those goals is to begin to regulate. What we'll see with some infants who aren't getting that co-regulation, that they will be in hyper arousal or that distress a lot, or the opposite, which I actually get very concerned about, are the babies that are really shut down. The babies who, it's like they stop signaling, they stop letting us know, or people in their environment know what they need. Because for some babies being born into a highly stressed family, having needs can actually be dangerous sometimes. That they could get yelled at. They could, when we talk about shaken baby syndrome. And so babies, again, they're very adaptive to their environment. One of the first things that we'll look for is that the baby, very, very young babies, the youngest referral that I had was a 10-week-old. And what we already noticed is that she was not making eye contact. So that looking away, babies who are distressed, when you think about what can they do, they're kind of totally dependent on us. What they can do is they can look away. And they can do that at birth. So that breaking the gaze is one of their strategies. And the other is just really signaling that distress and then shutting that down.
Talk a little bit about primary caretaker baby match, because I imagine sometimes you can have maybe a mismatch.
Well, and I think that sometimes that's why support networks are so critical, because as a parent, I don't think you can ever be 100% right in reading a baby's cues or have the ability to read and respond appropriately to every signal that a baby gives you. And quite frankly, it's not easy to be a parent of a newborn or a 3-month-old, or an adolescent for that matter. So I think the ability to balance maybe the incompatibility that might exist between caregiver and baby comes from sometimes outside supports. And sometimes that support is more specific to a coaching model, or sometimes it is. It's infant and early childhood mental health based therapy. So how can an outside person who has background in working with infants and toddlers and parents, who comes from a therapeutic background, how can they work with the relationship to kind of equalize the dance steps between the two partners? And I think it's a learning process, but babies teach us a lot. And I think that's why the more people who know about the importance of reading early cues and supporting people to read early cues, I think the less and less we're going to have partnerships that are compromised between.
And I just love what you're talking about right now, which is the idea, first of all, giving us permission that we don't have to be great at reading babies' cues all the time, that other people can help us learn how to do that, that it's a skill you can learn, so that you don't have to feel like you're in it by yourself, number one. And if you feel like, because as I'm thinking about this, if I now have to do this thing that I'm not good at, and I feel I have to do it all the time and by myself, my baby now almost becomes the signal of my incompetence. And that makes me kind of fearful then. And now I'm fearful in the presence of my baby. And that's not what I mean to communicate. But if we say that we have this notion that actually you can get help, and actually you can let other people help you, and if there are other people who are better at this in your life, let them help you.
Well, and we have a good friend, Marty Erickson, who's in the cities, and Marty, that her program, she has a radio program, a talk program in the cities, and she talks about good enough parenting. We don't have to be perfect parents. We have to be good enough, and we have to respond most of the time to what the baby is kind of trying to, pull from us. And certainly that when we look over, history, babies were raised in communities. They were raised in kind of extended family relationships, and that you had the wisdom of the other, people within those family systems and in the community that could also provide the care. And so we can get, there's some pretty significant research about people don't know who their neighbors are. And so moms with new babies can get more isolated. And so I think programs such as in our community, ECFE, we have some really wonderful ECFE,
Early childhood
family education programs. Thank you, Carolyn. That are available, and some pediatricians who, our collaboration with St. Luke's Pediatric Associates, that the pediatricians there, I can't say enough about in terms of their early recognition of some of the difficulties with the secure attachment.
And let's move into toddlerhood a little bit, so a little bit out of infants into toddlerhood. And in fact, there's a question, somebody calling about their great-grandson in Superior who crawls backwards and not forwards, and why. But that brings to mind, when you see a child doing something different than maybe what other kids do, at what point is it a problem versus is it just kind of like an amusing circus trick?
Right. Well, and I think, that notion of kids crawling backwards, I know more kids in my years of working with infants and toddlers and preschool kids who started crawling backwards. And I think it's that thing about, just like they practice attachment, they practice about how to move in space. And some people, the way that they practice best early on motorically is crawling forwards, but many people it's backwards. If the child's 3 years old and crawling backwards, that's a different story. And so that question about when is something significant enough to refer, in my work with parents, I used to be a birth to 3 interventionist, working with children who were at risk for a developmental delay or disability. I always said to parents, if you have a concern, refer, because there are people who can come and give you more information and help you think through your concerns and your child's developmental status. And we are very blessed, I think, in Minnesota, because we have an excellent, it's called Help Me Grow, and it's a program that will come out to homes and basically work with families to kind of think through what their concerns are. They'll do an intake of sorts to learn more about the child and the parents' concerns and ideas about the child, and so it can become a very nice partnership.
And in Help Me Grow is in our community is situated in our Duluth public school system, and you'll have OT, occupational therapists, speech therapists, and education specialists who can come out and do that early assessment. And we're paying lots of attention. And we keep saying the earlier that we can kind of be kind of helping families look at those concerns, the better.
Absolutely, because number one, the problem's smaller then, right? And not just the baby is smaller, the child is smaller, but the problem hasn't been around as long to entrench itself.
That's right.
And that we say that that's important with any problem.
Yes.
And my own experience in working with parents is that parents have often an excellent sense of something's wrong and something's not right here. And what you were just saying, Mary Ann, is we're giving you all permission. If you have that sense, don't be hesitant to go and ask for help. You need to ask for help. We are out of time. This could have been, at the beginning of the show, Mary Ann asked me, now, is this an hour show? And I said, no, it's only 30 minutes. But at the end of 30 minutes, you'll wish it was an hour. I think we learned a lot tonight. First of all, we learned you don't have to be the perfect parent. You can just be the good enough parent. Look at those cues. Learn how to read those cues of your baby. And if you don't know how to do that, or if you have some questions about that, get the village in to help you learn. If you have questions, ask. If you think you might have postpartum depression, go get help. Your postpartum depression will last a lot less longer than if you don't get help. There's no need to suffer. Thanks again to all of you for being here. And don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of our topics and resource links, and read my blog, the place where I will answer more of your questions right here. Please tune in for next week's show when we talk about learning how to cope with a life-changing medical condition. I'm Dr. Carolyn Phelps. Thanks for watching, and good night.